Hello, 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 my friends. My name is Jill Osborne. I am the president and founder of the Interstitial Cystitis Network. It is Sunday, May 16th, and it's time for another support group meeting. Hello, hello, hello. All right, it's always a bit of a bear getting all my computers all set up here. Okay, hold on. All righty. I think we're about as good as it's going to get. I think we're as good as it's going to get today, my friends. All right. Hello, Sherry. Nice to see you. All right. So let me introduce myself. My name is Jill Osborne. I am the president and founder of the Interstitial Cystitis Network. It is Sunday, May 16th. It is time for another IC support group meeting. I have a few announcements to make, including some updates. But my purpose in doing these meetings is to make you so strong, so knowledgeable, so informed that no one can mess with you again. I don't want anybody to ever demean you, insult you, imply that this is not real, imply that this is all in your head, imply that you're stupid, all that sort of stuff that we all get when we have a invisible illness, right? Although injury for many of us. So what we're going to do today is we're going to take questions. I'm going to give you some new content. We might do a Zoom meeting. We'll see how it goes. I am recovering from my epidural on Thursday. I was in a hell of a lot of pain yesterday. So we'll see how it goes. Now, I just got to fix one camera here. We're simulcasting live on YouTube and Facebook right now. Hello, Ann. Hi, Carolyn. Nice to see you. Hold on one sec. Dar says, I wish the IC network would talk about root causes. I would be happy to talk about root causes. Give me one sec. I just got to try to fix something here. Hold on. There you go. You just got to, Facebook, you just got to up close and personal look at my hair. Hello, Helen. Hello, Ann. Dar says 20 years ago, I was told that I had IC. Right. 20 years ago, we were all told that we had IC because that IC is a grab bag diagnosis, hon. When they can't figure out why you have frequency, urgency, pressure, pain, they're going to label you as an IC patient. No doubt about that. But today we know that that potentially is incorrect. So let's talk about this for a moment. So what is interstitial cystitis? Interstitial cystitis means that you've got frequency, urgency, pressure, pain, but you don't have the common causes of that. Your UTI is negative. You don't show any UTI. Your cultures are negative. You don't have bladder cancer. They can't find any other probable cause for your symptoms. So they're just thinking, okay, you've got this weird, unusual condition called interstitial cystitis. So if you're a man, you might be labeled as chronic prostatitis. And back then, we were told it was incurable. Back then, we were told that there were only two treatments, Elmer and DMSO. We were told that we were always going to live with pain, yada, yada, yada. Remember, I had a doctor tell me, you will forever live in severe pain. This is your life. Get used to it. And that was when I started fighting back. And he was wrong because I don't have severe pain anymore. It's really rare that I ever have pain. But we have to understand how things have changed. All right. A lot has changed since then. And hold on a sec. I'm still working. I'm still trying to work on these two computers. Easier said than done. Okay. So let's just talk about this for a moment. So 150 years ago, when IC was first described in a medical journal, if you read that journal article today, it would be perfect. This is a patient who has frequency, urgency, pressure, pain. Of course, 150 years ago, generally what they were looking for was bladder stones. Bladder stones were very common back then because they preserved meats with heavy salts and things like that. Back in around 1920, Dr. Guy Hunter was the guy who invented the cystoscope. And he was able to look into our bladder for the first time, where he saw ulcers wounds in the bladders of IC patients. And so that's why we call them Hunner's ulcers, Hunner's lesions. So back in the 1920s, they had their little bit of an aha moment when they went, okay, look, there's a bleeding wound in the bladder. That must be interstitial cystitis, okay? Again, we're talking 1920. Then around 1940s, late 1940s, somewhere in there, better cystoscopes were invented, better visualing was invented, and they started seeing something different. Rather than seeing big wounds in the bladder, what they saw were little tiny red spots in the bladder that they called petechial hemorrhaging or glomulations. So now we've got this debate. We've got, okay, is IC this big wounds or is IC little wounds? Big lesions, little tiny wounds. And so for about, I'm going to say the 1950s, all the way up through 1980, 1985, people considered, the researchers and the clinicians considered both IC. They both thought that they were relevant, right? But it was in 1987 that the National Institutes of Health created their first research diagnostic criteria for IC. And the purpose of that criteria was to make sure that they were studying similar patients. And so in that criteria, they required that you have either Hunner's lesions or these little red spots called petechial hemorrhaging. But here's the reality. Is another researcher came along and said, but you know what? Guess what? If we look at a normal bladder and we stretch it with water like you're doing, red spots happen, petechial hemorrhaging happens. And so when his paper came forward of a couple dozen patients who had no bladder symptoms, who were scheduled for a tubal ligation, and they let them do a hydrodistension to look at their bladder, guess what? They all had petechial hemorrhaging. So it's at that point that people started going, uh-oh, maybe the petechial hemorrhaging itself is actually being caused by the testing. And in fact, today now actually at the AUA meeting in 2020, they've pretty much thrown out petechial hemorrhaging as a meaningful finding. So the question comes back to, what the hell is IC? What the hell is it? And this, and in fact, hold on, let me get this book here. Oh, no, I have it right here. So here's the reality. We still have patients who have frequency, urgency, pressure, pain. Some of you have lesions. Some of you legitimately have little wounds in your bladder that are bleeding profusely. We call those Hunner's lesions, about 10%. There's a debate about the percentage. But what about the rest of us? What about the rest of us? Like, you look at my bladder, and I have a completely normal bladder. There is nothing wrong physically with my bladder. And yet I went through years of severe pain. Why? Why did I go through severe pain? This is how the IC movement has expanded. This is what we're doing today. We're doing something called subtyping. We no longer make a diagnosis of interstitial cystitis, in the sense that it's not meaningful. It doesn't tell you or your doctor what you need to do next. What we do now is a more individualized diagnosis of IC. We do subtyping. Now, if you happen to be in Europe, there are 12 variations of IC. If you were in Europe, they would be doing a hydrodistension. They would be doing a biopsy. They would be ruling out all sorts of other conditions, and then they would classify you in a 12-point system. In Canada, they use a system called U-point or input. In the United States, we don't have a nationally agreed upon system, but I use a system that was created by Dr. Christopher Payne, who ran the IC research program at Stanford University. And he focuses on 5 core variants of IC. And when he introduced his system about 6 or 7 years ago, one of the things that he railed at is that so many of you are told that this is an incurable bladder condition, and that is wrong. For some of you, it is curable. For many of you, it could be curable. But the challenge with the diagnosis of IC is you don't know what to do next. Neither you nor your doctor know what to do next. You don't have an intuitive treatment plan. And if there's one thing we know in the IC world, is that a one-treatment-fits-all approach doesn't work. There's one thing we know in the IC world, is that bladder therapies don't work for a lot of us. A lot of us. So the question is why? What the hell is going on? So using the Chris Payne system, we're going to focus on 5 core variants. So let me get my slides here real quick. Hold on. So we're answering Anne's question of, can you just please get to the bottom of what the hell IC is? So let's do that. Okay. So using the crisp point system, the crisp pane system, here we go. It's always hard because I think YouTube reverses it. So for YouTube, if it's backwards, I apologize. So Chris Payne is now at Vista Urology, which is considered the premier pelvic pain clinic in California and on the West Coast right now. All right, so IC subtype 1. IC subtype 1 is Hunner's lesions. So these are the people who legitimately do have a big bloody wound in their bladder. And now we know why that's happening, because for some of you, that's a viral infection. We have research now from Europe and the United States and our own National Institutes of Health that has connected a virus called the polyoma BK or the polyoma JC virus in the urine of patients with Hunner's lesions. Hunner's lesions have always been considered the most severe form of IC. Hunner's lesions have always been considered the most difficult to treat form of IC. Hunner's lesions don't respond to Elmeron. Hunner's lesions don't respond to DMSO. Lesions require lesion-specific therapy. If you treat the lesion correctly, the pain usually goes away or improves dramatically. So with a lesion, what are we going to do? We're going to inject it with a steroid. We're going to cauterize it, or with a laser, we're going to do hyperbaric oxygen therapy, something like that. So Hunner's lesions now are believed to be viral infections in many patients. So why does the polyoma BK virus get turned on? Now, we all have polyoma. It's part of the urinary biome. We are not, this is not a sexually transmitted disease. Nobody's talking about this like a sexually transmitted disease. What we are talking about is that the biome in our body has been changed / damaged / potentiated, whatever. I don't even know the right word for that. Polyoma BK virus, polyoma JC virus gets turned on in patients who are immune compromised. And so you will find many articles on a condition called hemorrhagic cystitis, bleeding cystitis, a bladder that is hemorrhaging. And the cause of that is usually a polyoma infection. And so Hunner's lesions now are believed in many patients to actually be polyoma viral infections. Okay. And you can read more about that over on our website, icnetwork.org. IC subtype 2, bladder wall driven. So this is legitimately that, yeah, man, your frequency urgency pressure pain is definitely being caused by something going on with your bladder. The question is what? Now, how do we know your bladder wall is driving your symptoms? You're going to have pain as your bladder fills with urine that is relieved by urination. So the fuller you get, the worse you feel. And as soon as you pee, you feel better. And I can explain that. Let's see. Let me get this picture. All right. So here are a bunch of pictures of Hunner's lesions, right? And then this is a picture of more of an irritated, damaged bladder wall. Okay. So now imagine everywhere it's red, you have the equivalent of a wound. I mean, obviously, it's oozing blood. As your bladder fills with urine gets into the wound. It hurts. So the fuller you get, the worse it feels. Ow, 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 ow. Oh my God, where's the bathroom? I need an effing bathroom right now. And then as soon as you pee, bam, the pain goes away. Why? Because urine is no longer touching the wound, right? So we know that your bladder wall is driving your symptoms if you have pain as your bladder fills with urine that is relieved by urination. So what are we going to look at there? We're going to look at 3 fundamental things that can happen with the bladder wall. The first thing we're going to look at is chemical irritation. If you're going through chemotherapy, it's called chemocystitis. There are chemicals in chemo that are badly damaging to the bladder wall. If you're drinking a lot of diet soda, if you're using ketamine, if you've been exposed to some antibiotics that are damaging to the bladder, these are all things that can cause chemical injury of the bladder. You guys, you got to remember your bladder was designed for life 5,000 years ago before modern industrial chemicals. And so a lot of the things that we have in our environment today have the potential of being irritating. Your bladder was not designed for acid all day, unless maybe your ancestors are from the equator where you had fruit year round. But for me, having ancestors in Norway, hello, we only had fruit once a year. We only had acid once a year, and that was when the berries were ripening, and we ate them if we didn't eat them when they were super ripe. So chemical irritation is the first thing we're going to look at. The second thing we're going to look at is estrogen atrophy. Hello, aging my women friends. It turns out that your bladder is part of something that we call the urogenital sinus. What that means is that when you and I were little tiny cells in our mom's uterus, there was one group of cells that diversified to create the urogenital sinus. It meant it created the urethra, the vulva, the vagina, et cetera, et cetera. So the bladder and the urethra are mucous membrane organs, just like your vulva and your vagina are. And they need estrogen to produce that nice, thick coating of mucus. So how does the bladder defend itself? It has a really thick coating of mucus in it, and that mucus works as a barrier. It protects the fragile cells from whatever irritants are in your urine. The problem is that mucus is estrogen dependent. So when you're young and you have lots of estrogen and you have lots of mucus, you can get away with stuff and your bladder can defend itself. But when you're older, you have much less estrogen, you have much less mucus. What does that mean? It means that your bladder's ability to defend itself is now compromised. That's not a disease. That's just getting older. It's called the genitourinary syndrome of menopause. So if your symptoms began after a hysterectomy, when you were going through perimenopause or over the age of 50 or 60, and you didn't have any history of bladder stuff before then, the odds are we're really looking at genitourinary syndrome of menopause. The great news here is we have a fabulous new book coming out called The Menopause Manifesto by Jennifer Gunter. It will be out in about, I think on the 24th. Can't wait to read it. So again, if you have symptoms that start after the age of 50 or after hysterectomy, or if you've been on Lupron, we're always going to look at the quality and health of your skin. We're always going to look at the role of estrogen and estrogen atrophy. If you have what we call urine burn, where as you're peeing, your urethra is burning, but more importantly, your vulva is burning, where your vulva feels really hot, like your urine feels really hot. Your urine is not hot. That heat is a reflection of the health of your skin. The hotter it feels, the drier your skin. And so therapeutically for these patients, what we're going to do is potentially give them a topical estrogen, because when you give that skin estrogen, it starts to produce its own mucus. And that's important. There's also a group of patients who get recurring UTIs after menopause, where you legitimately have infection once a month, once every 2 weeks, you get an infection. Why? And that comes right back to the quality and health of your skin and your skin's ability to defend itself. So generally, with the research that has been done with these patients, what they find about 24 hours before the bacteria arrives in the bladder, it's happily living in the vagina. And so the researchers were then asking, well, what's happened to the normal vaginal defenses? And the answer goes right back to aging and estrogen atrophy. So therapeutically, for those patients who are getting recurring UTIs, in addition to treating the UTI, they're going to give you estrogen so that you can build bodily defenses again. Okay. Then the third thing that we're going to look at for IC subtype 2 bladder wall driven is chronic infection, because chronic infection happens. Some of you legitimately do have infection. The question is, what type of infection do you have? Now, a lot of you are thinking it's bacteria, but guess what? For a lot of you, it's actually fungus. You actually have candida infections. And in fact, that comes straight from our own National Institutes of Health MAP Research Network, who were studying the urine of patients who were flaring. And what did they find? An overgrowth of candida. And, remember, the bladder only knows one language: frequency, urgency, pressure, pain. The only way it can tell you that there's a problem is by giving you all the symptoms that you associate with infection. But So you could have a bullet wound and it would feel like infection. You could have a stab wound, it could feel like infection. You could have cancer and it would feel like infection. You could have a fungal infection and it would feel like a bacterial infection. And yes, some of you do have chronic bacterial infections, a small subset, not everybody. If you've attended my meetings, you know that I don't believe in broad strokes for everyone. There are people out there who believe that everybody has chronic bacterial infection, and that's just not true. That's just not true. This is actually one of the smaller subtypes, but we have to be open to the possibility that you could indeed have a chronic infection, especially if you are older. Now, a paper crossed my desk yesterday, and my back was killing me yesterday, and so I couldn't work here at the computer. And it was something about ureaplasma and mycoplasma, and I will maybe later in the meeting I will come back to that. Okay. So anyway, IC subtype 2, bladder wall driven. All right, IC subtype 3 is the much bigger subtype than IC subtype 2, pelvic floor driven. So these are the patients whose symptoms began after a physical trauma, having a baby, having a surgery, falling on your tailbone, being in a car accident, being raped, being abused. Or if you were an athlete, if you have a history of falls, were you an ice skater, a gymnast, a football player? Were you in the Army? Were you a paratrooper? Did you take any severe pelvic traumas? I was working with a Denver Bronco football player a couple of years ago who this happened to, where you're at the peak of your career, life is going well, and then bam, one day, extreme frequency urgency. What the hell is going on? Now, if you're like most patients, especially men, they're going to say, oh man, you must have prostatitis. Let's give you antibiotics. So they throw you on antibiotics for a period of time. They don't work. You go back to the doctor. The doctor goes, oh, let's give you some prostate meds, or let's give you some overactive bladder meds like ditropan or Detrol. They don't work. You go back to the doctor, and the doctor goes, God, I hate to break it to you, but I think you've got interstitial cystitis, this really incurable condition with severe pain. And then they put you on IC meds and they don't work. And there's a reason why they don't work, because fundamentally, your problem really isn't with your bladder. Your bladder is a secondary victim of your injury. Your injury. And so let's see, how do I want to say this? Let's say that your symptoms began after you fell on your tailbone. So I'm thinking of one guy in particular that I worked with who was sliding in his socks on his wooden floor, and his legs swept out underneath him, and he landed right on his tailbone, and then he fell down his stairs, tailbone, 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 tailbone. So he had like 8 or 9 tailbone injuries, and I think it was just within a day or two that all these symptoms of frequency urgency started. So what happens is when you fall, you suffer a compression injury. All of your weight lands on a small area on your butt. And so your muscles are squeezed. Then your blood vessels are squeezed. We know blood vessels are squeezed and damaged because you get bruising. And then the blood vessels that support the nerves get squeezed. And guess what? Nerves can't function correctly if they don't have good blood supply. And ultimately, in the end, what you've got are hypertonic muscles so tight they're restricting blood flow. And when the bladder doesn't have good blood supply, it's very hard for the bladder wall to be healthy. And so for this group of patients whose symptoms began after physical trauma, let me just say the symptoms are very similar: frequency, urgency, pressure, pain. But rather than being sharp pain, it tends to be duller pain. It tends to be achier pain. It has a burning quality to it because muscles that are working hard build up lactic acid that causes a burning sensation. But the number one symptom we look for in somebody with pelvic floor tension is difficulty starting their urine stream. If you sit on the toilet or standing in front of the toilet and you cannot release your urine normally quickly, that means your muscles are probably tight. And so therapeutically, our priority for you is going to be to restore blood flow. How do we do that? With pelvic floor physical therapy. And we knew that in 2008, 13 years ago. We knew that pelvic floor physical therapy outperforms bladder therapy in the great majority of patients who have done it in that study. That was a multi-center study done by the National Institutes of Health. So in 2008, when that data was released, the IC world was turned on its head because up to that point, everybody was going incurable bladder disease. We're like going, well, wait a second. If it's an incurable bladder disease, why would physical therapy help? Uh-oh, wait a second. Maybe that's because for some of us, myself included, it's a muscle problem. It's not a bladder problem. The bladder is a victim of an underlying abnormality, a muscle issue. I see here, let me get a drink of water. Hold on a sec. Actually, chamomile tea. I see subtype 4 is pudendal neuralgia. Now, these are the patients who have pain when they sit down that is improved when they stand up, or you have pins and needles, or you have sciatica. And generally that happens because you have muscles so tight, they're compromising a nerve. And so therapeutically for this group of patients, we're going to be doing two things. We're going to be trying to release the nerve, and we're going to be trying to calm down the nerve. So we have to find the muscle that is compromising the nerve. If you have sciatica, it's probably going to be a piriformis muscle. And then they're going to do therapies that are going to calm your nerves down overall, maybe over-the-counter Peora, PEA, or gabapentin, amitriptyline, something like that. And then the last subtype is, using the pain system, is central sensitization, chronic overlapping pain conditions. So this is my subtype along with subtype 3. So these are the patients who not only have IC, they've got IBS, they got vulvodynia, we've got wicked sensitive skin, we have an incredible sense of smell, we can smell things that other people can't smell, and smells really drive us crazy. What's going on with that? That's actually a central nervous system problem. What that means is that our central nervous system has become hypersensitized. It takes less stimulation to give us pain. And I've talked about this in depth, especially in the last 3 to 4 months. I don't really want to talk about it in depth now, mostly because my back hurts and I don't know how long I'm going to be able to do this here, and that's a long discussion. But generally, what we have found with the research from the Chronic Pain Research Alliance, as well as from the National Institutes of Health, is for those of us who have chronic overlapping pain conditions, our brains are stuck in fight or flight. Our brains are scanning differently. And I attended a conference last fall, and what that conference showed is that for 80% of the people that this happened to, especially children, there was a major physical trauma that did some damage, like getting hit by a car or falling or breaking your tailbone, stuff like that. But for about 20%, there was a history of abuse or bullying. And that's the best way that I can explain this. Imagine being a student and having a terrible bully at school. I mean, who hurts you like every day when nobody else can protect you. And so if you're that child, you go into fight or flight as soon as you wake up in the morning, because you've got to go to school and you know that there's this big scary guy at school who's going to hurt you. And then you walk to school, or you get driven to school, and you walk into school and you're looking all day, you're on hypervigilant. You are fight or flight all the way around. And remember, fight or flight means your body's trying to protect you. Your brain thinks your life is at stake. So it's preparing you to run or fight for your life. Your brain thinks your life is in jeopardy when you're that scared. And the only time that goes away for that child is when they get home at the end of the day. And maybe for a couple of hours a day, they're fine. Until mom says, hey, hon, you got to get ready for bed, got to go to school tomorrow. And that jacks up the sympathetic nervous system, that jacks up fight or flight. And before you know it, a couple of years go by. And that patient is now stuck in fight or flight. You're stuck in fight or flight. But we can turn it off. We know how to turn it off. We know how to turn off the sympathetic nervous system and turn on the parasympathetic nervous system. I don't want to do that right now, but we might do that in a little bit. So you can read all about that over on our website. So we're getting back to this question on that was on from Dar on Facebook. Why don't you get into the fundamentals of IC? There you go. Those are some of the fundamentals. But there are a hell of a lot more. If you look at the American Neurology Association guidelines for IC, they admit that a lot of patients don't respond to bladder therapy. Now, we understand that. We understand, you got to remember, Western medicine kind of fails the pelvic pain patient because doctors stay in their sandbox. Urologists stay in the urinary tract. Gynecologists stay in the reproductive tract. Gastroenterologists stay in the bowel. They don't necessarily look at relationships, how organs and structures are interacting with each other, especially muscles. But the other thing we have to rule out are things like fibroid tumors. Could you have a fibroid tumor pushing on your bladder? Could you have a Tarlov cyst coming off your spinal cord, pushing on the nerves that support your bladder? Could you have endometriosis? Could you have another condition which is also victimizing your bladder? And that is where this book, my friends, is the life-changing book. It's called Facing Pelvic Pain. If you have not responded to therapy, if you're getting worse rather than better, if you don't know what the hell is wrong with you except your bladder looks good, you need to get this book. And it's free on Kindle Unlimited. It's free. It's free. Come on, get it. It's free. This is the book we needed 30 years ago. It is stunningly good. And so this is written by leading experts with Harvard Medical School, Massachusetts General, and also from around the country. I'm also a featured author in this book, which was an honor. Let me tell you, it's a tremendous honor to be asked to contribute to it. It goes over every other condition which could cause the symptoms that we associate with IC. One of the things, so I'll give you a little bit of trivia here. I mean, not trivia, just like I always like the kind of funky, interesting stories. Do you strain? Do you strain when you urinate? Do you sit on the toilet and push and push and push and push? Even when your bladder's empty, you feel such strong urgency that you feel compelled to strain. Number one, don't do that. Don't do that. Never ever strain. You should not be straining to have a bowel movement. You should not be straining to urinate. I was working with a woman about 2 weeks ago who didn't know that. And so even when her bladder was empty, she had extreme urgency. So she would sit on the toilet and strain for like 20 minutes and nothing would come out except her urethra. She strained so much that she started pushing the skin of her urethra out of her body, and she developed something called a urethral caruncle. Think about it's kind of like a hemorrhoid, but it's like a mini hemorrhoid of the urethra. Only it's not a blood vessel; it's actually tissue. It's actually the tissue. So urination should always be about relaxation. You feel you feel the need to urinate, you go to the bathroom, a muscle relaxes, a sphincter opens, and you pee, and you let it out easily. If you can't do that, if you're sitting there 5, 10, 15, 20, 30 seconds before you can release urine, that means that your muscles are tight. Potentially your muscles are tight. There are other things that could be, but usually that means that you have tight muscles. So the last thing you want to do is strain, which is going to tighten your muscles even more. Who was that? Somebody was listening to a doctor like 10 days ago who said, you should only be on the toilet 2 minutes. If you're on the toilet longer than 2 minutes, there's something wrong. And I thought that was really interesting. Okay, so anyway, Dar, there you go. And Dar says here that you can have Lyme. Yeah, you absolutely could have Lyme. They definitely found Lyme in the bladder tissue. We also now believe that COVID can be infecting the bladder wall. We are doing the only IC COVID study on the IC Network website, and 75% of IC patients who get COVID report a severe worsening of their IC symptoms. And for some of them, it's a dramatic worsening of their IC symptoms to the point that we actually believe that they're getting a COVID infection infecting their bladder wall. So now you can see why I don't believe in one. You can't paint broad strokes in this patient community. There's no way you can do that. All right. So hold on a sec here. YouTube, I can't see what you guys are writing. Hold on. Hello, Donna. Hi, Lisa. Nice to see you guys. I'm a little funky today, guys. I might be a wee bit hyper today too, because I'm still recovering from this dramatic and remarkably painful epidural. I should show you my back. It's all marked up where they were putting all the needles. They're trying to calm the nerve 3 coming off of my spinal cord because I compressed a couple of discs that damaged the nerves. All right, so hold on a sec. Let me look at you guys here on Facebook here. Lori says, can long-term use of aloe vera capsules cause liver issues? I take 3 in the morning and 2 in the evening to help. I would love to see a really expanded safety sheet on aloe. I've looked for one. I could not find one. Aloe vera is kind of classified almost as a medical food. It's considered remarkably safe. But that said, for those of you who know me, you know I don't believe in taking a lot of anything. I don't believe in adding a lot to anything. So if you have doubts, I would cut it back or talk to your doctor. Isabel said, I just had a microdiscectomy for the same back issue. Oh, Isabel, I would love to say, when they were doing it, and they were injecting the lidocaine, they were going, okay, did the pain go away? Did the pain go away? And I'm like going, no, no, nope, nope, go away now. Nope. And the pain never went away. I still have a vice around my thigh, which sucks. I mean, it might be a little tiny bit better, but they say 2 weeks. So Isabel, I'd love to talk to you at some point in time about that. Anne says, do you have to have pain with IC? I was told IC had no pain. Our body interprets pain in different ways. For some people, pain is interpreted as pressure. So if you feel a sense of pressure, that's kind of believed to be one variant of pain. The way we differentiate between overactive bladder and interstitial cystitis is actually over the symptom of urgency. If you are running to the restroom to reduce discomfort and or pain, that means that you're going to be in more the bladder pain category. If you are running to the restroom because you're afraid you're going to leak, that's the overactive bladder category. Okay. But no, not everybody has pain. A lot of people just have frequency urgency. A lot of people are diagnosed with IC, just a frequency urgency. You might not have pain, but if you're getting up every 20 minutes to pee, yeah, it's a problem. Wendy said, I've had InterStim for over 15 years and I couldn't live without it. Glad, honey. I'm glad that it's working well for you. InterStim, you guys, neuromodulation is a step 4 treatment option for IC. It's not easy. There are a lot of ramifications of having a neuromodulation. And so when we look at our treatment protocol, we, number one, want to focus on your subtype. I mean, if you've got Hunter's lesions, InterStim doesn't make sense. If you've got pelvic floor, InterStim might help relax muscle a little bit. But neuromodulation is particularly helpful for patients who've got some nerve involvement going on, because you use a mild electronic impulse to kind of re-regulate and calm the nerves down. We've got 2 forms of neuromodulation. We've got ankle stim, also known as urgent PC or post-tibial nerve stimulation, as well as pudendal or sacral neuromodulation, which are known or go by the name of InterStim. Lauren says, what subtype would I be if you have a hormone imbalance? I have extremely low testosterone. You would be an IC subtype 2 bladder wall driven hormones. And I didn't talk about that. There's definitely a group of patients who are struggling with funky hormone issues. It's just not well defined right now. For some of you, you flare when you're high progesterone. For others, you flare when you're high estrogen. And it's a bit of a mystery there. Angela says, I have a tickle in my tailbone. I have to tickle my tailbone to start the flow every single time. I don't get that. Oh, huh. I don't get it. I don't get it. Sherry says, okay. And that's on the right diet, very few flare-ups. So as I was pondering what I wanted to talk about today, I actually kind of wanted to talk about absolutes. What are the absolutes? If you are not diet sensitive at all, if you can eat anything and you do not flare, your bladder is healthy. You do not have a bladder wall issue. You can have frequency urgency, but if you can drink coffee, if you can drink lemonade, if you can eat chocolate and you don't flare at all, what does that tell me? That tells me that your bladder wall is very healthy and that there's something else victimizing your bladder wall. So I was trying to think of the absolutes in the IC world. What are the absolutes in the IC world? Carol says, can you repeat what you just said about COVID? Carol, we are doing the only IC study with COVID, and for IC patients who get COVID, 75% report that their IC symptoms get worse, and about 25% report that their IC symptoms become so severe that their normal flare management tips and therapies do not help at all. And our guess on that, and I bounce this off of a couple of really top doctors, is that for that very small group of patients, they actually have COVID live in their bladder wall. We have 14 studies which have found live virus in the urine of IC patients. We have 4 studies which have found active COVID kidney infections. So it's not much of a stretch to think that COVID could be infecting the bladder wall also. Hi, Kayleen. Kayleen says she has something to tell me privately. I'm dealing with a nasty UTI. Okay, hon, why don't you call me on Tuesday? I'm gonna still need another day or two to recover from this back thing I went through. It was not fun. All right, so I need to give you the Sister ProTech update. So, we have a lot of supplements now that are commonly used by IC patients. The American Neurology Association supports and encourages their use in the AUA guidelines because they have far fewer side effects than traditional medications. And so the supplement that was the top dog for many, many years was called Cysto ProTech. And it was created by Dr. Theo Herides, one of the original National Institutes of Health funded IC researchers. And when his story is interesting because he was asked to investigate the safety of supplements for the state of Massachusetts. And while he was doing that research, he kind of went, I wonder if this could help IC. And he created his product line. He created Alganot first, which means no pain in Greek because he's Greek. And then he created Cysto ProTech. And for about 20 years, Cysto ProTech was by far the top supplement in the IC world. But it had some hiccups. They sold the US licensing rights off, and it's been sold to numerous companies. There was a cancer warning on the label 3 years ago. It was just a disaster. It should never have happened. It was supposed to be reformulated by the current owner. They didn't do it. It's done now, but anyway, we couldn't get it for 10 months. And now this year, we have not been able to get it for 5 months. But I have great, great, great news. And that is that Dr. Theo's company is finally buying it back. They're getting it back. And so they're already halfway through the negotiations. It will have a new label. It is now going to be sold by the IC network and the manufacturer. I haven't seen any artwork yet, but here's the rub. We had been waiting for 5 months for the next production run, which they finished 10 days ago with the old label, the turquoise label. And that label is this label, right? So for those of you who are looking for Sister ProTech, this has been the label for the last 7 or 8 years. So now they finally have thousands of bottles. We've been waiting. Wrong label. So now they've got to send 8,000 bottles back to the manufacturer to be relabeled. So I still do not have Sister ProTech. We do not have Sister ProTech. A month, maybe. So just know that yes, the delay is frustrating. You know, the challenge that we have here is a lot of these companies think of these supplements as vitamins, and they're like, you don't need your vitamin for a couple of months. They don't understand that for people with IC, they really help control symptoms. And COVID has messed up the supply chain. It's messed up manufacturing schedules. So it wasn't that the company did anything wrong. It just things added up and we ended up with this massive delay. So hopefully we will have the brand new Sister ProTech with the brand new label within a month. And the price is going to be lower. They told me that they were going to drop the price. So as soon as we have that, I will let you know. In the meantime, of course, most patients have transitioned over to CystoMend. Let's just let me just show you. Just so that you kind of have an idea of what is available out there. CystoMend is the closest that is out there that compares to Cysto ProTech. So CystoMend is available $39, I think. Bladder Builder is, in my opinion, the best supplement on the market today. And the reason why is, in addition to having the chondroitin and the hyaluronate for the bladder wall, it's got PEA for pain relief. And I've talked about this before. You can find the 1-year follow-up study we did with this. So this has been out now for about 2 years. And 60% of the patients who have tried Bladder Builder absolutely love it. 25%, 22%, somewhere in there are now pain-free using something like this with PEA in it. Shorter flares, fewer flares, less painful flares. Bladder rest, for those of you who are super sensitive and you're afraid to try anything because you never know how your body's going to react. Bladder Builder is the kind of clean, pristine supplement for people who are super sensitive. If you love the soothing effect of aloe, but it's not quite enough, Aloe Path now has aloe combined with PEA in it for that pain-reducing effect. And of course, the most exciting thing we have is called Piora. 2 years ago, Italian IC researchers brought a PEA IC study to the American Neurology Association. PEA, also known as palmitoyl ethanolamide, has been used in Europe for a couple of decades for chronic pain, as well as acute pain. It has been studied extensively for things with nerve-related pain, so sciatica, fibromyalgia, burning mouth syndrome. They brought their first ICPEA study to the United States, and the data was nothing short of astonishing that by month 3, 87% of patients using PEA and resveratrol had a significant reduction in their pain, and by month 6, again, 20 to 25% were pain-free, and the rest were doing remarkably better. And so you're going to see now, my prediction in the future is you're going to see PEA added to any of the supplements that are kind of targeting bladder health. And then also for people looking for a vitamin, the woman that I was working with who was straining all the time, like straining. The other thing she was doing is she was, and she was clearly estrogen atrophy. There's no doubt about it. Her doctor told her she was very, very dry. Is she was taking this super strong vitamin twice a day with over 500% the daily recommended dose of vitamin C in the form of ascorbic acid. And so she was bathing her bladder in acid morning and evening, her dry bladder that didn't have a lot of protective coating. And so that's when, if you feel like you do need a vitamin, you want to make sure you use a low acid multivitamin like Bladder Smart. This is the one that I use every night. Never flared from it. I have flared every time I've tried a one a day or a Centrum. Never flared with the low acid vitamins. All right. So there are things for you to try, my friends. There are lots of things for you to try, but ultimately, listen, we can't have a good discussion about what your treatments are until we understand your unique anatomy. It doesn't make sense to treat your bladder wall if your bladder wall is healthy and your muscles are tight. If your muscles are tight, you got to invest your money in repairing your muscles. And if you're somebody who has IC and IBS and vulvodynia, we have to be working on calming the central nervous system down. So focusing on bladder therapies and bowel therapies, they might deal with some of the incidental symptoms like the cramping, but it's not going to solve the problem. What's going to solve the problem is calming the central nervous system down for IC subtype 5. Does that make sense? Kind of, sort of? Carol says, I'm afraid of getting the vaccine because I have extreme chemical sensitivity. Any thoughts on that? Carol, listen, you have to, number one, you have to talk to your doctor about it. Any deep concerns you should talk to them about it. But this is what I have observed. And this is in our meetings here with lots and lots of people attending. I'm going to say 90 to 95% of IC patients who get the vaccine have no problems at all. I had it. I had both. I had no bladder flare. I had Pfizer. But about 5% are reporting some flares, but the flares are still pretty short term, like a 5-day flare. So I've only worked with one patient in all this time who had a severe reaction, and she had an underlying kidney abnormality, and it affected her kidneys. It had nothing to do with her bladder. So when you compare the risks of the vaccine to the risks of COVID, especially the long haulers, I don't know if you saw the data which showed that patients who are long haul victims of COVID, actually, I think 30% of them have cognitive decline. Remember, COVID is not just a respiratory virus. It is a circulatory virus. It attacks the circulatory system. And that's what makes COVID just so incredibly devastating. And so it's scary to think about. I will admit that when I went and had my vaccine, both of them, my stress level was a little high. I got to tell you, I didn't even feel the first shot. I had no reactions from the first shot. I did not even have a sore arm from the first shot. My mom had a sore arm for 2 days. I didn't. And then having the second shot, that's when you're going to feel potentially the chills and the fever. About 12 hours later, you're right. I definitely started feeling fatigued. I had a little chills, a little fever for about 2 days, went away. Life is good again. Afton says, I've been diagnosed with pelvic congestion syndrome. I had my left ovarian vein embolized 6 weeks ago. Urinary symptoms seem to be worse, as well as the prolapse symptom. Afton, now that's really interesting. So you guys, pelvic congestion syndrome is the equivalent of varicose veins in your pelvis. And so the veins become super dilated. And as the day goes on, you feel like you're carrying a heavier and heavier weight in your pelvis as the blood kind of pools in your pelvis. The nice thing about pelvic congestion syndrome is it's pretty easily treatable, where they work on the vein. And here we have Afton. Was it Afton? Yeah. So she had her left ovarian vein embolized, but her urinary symptoms are worse. I can't imagine physiologically what would be driving that. I think I would wonder if just the procedure was more painful, a bit more traumatic, if your muscles are just tighter now. I would be except you've been diagnosed with a uterine prolapse and a rectocele. You have burning after urination and some bladder irritation. Could the prolapse contribute to that? Yeah. Yeah, as long as you have a prolapse, you're going to have things that are kind of flopping over and out of position, especially if your bladder is bent over. Your bladder might not be draining properly. You could be getting more infections from that. Okay, this is the mystery. This sound has now started. This started 2 weeks ago in my live chat. I have no idea what that is. That is so weird. All right. Afton, it's all involved. It's all involved. You've got muscles that are abnormal. You've got veins that are abnormal. You've now got a prolapse. Did they surgically repair the prolapse? Jessica says, I was told by my urologist to try Elmoron. I told her no. I didn't tell her why. I didn't mention the lawsuits and the vision loss. She put me on hydroxyzine. Not sure if that's a good med. What's your thoughts? And saying hello from Florida. Thank you, Jessica. Well, apples and oranges. Elmoron is a bladder coating. It acts to protect the bladder wall. And of course, we now know that Elmoron is linked to retinal damage and potentially blindness. And so Elmoron is very quickly not being used. Hydroxyzine is an antihistamine, completely different method of action. So the hydroxyzine can help calm some of the inflammation that might be happening in your bladder wall. Some of that mast cell, your bladder wall gets irritated, let's say by food. Mast cells then trigger histamine. Histamine causes the swelling, the itching, the redness, et cetera, et cetera. And so one of the ways we used to describe IC is it's like having 100 mosquito bites at once in your bladder, which makes sense when you think about this picture I showed you, right? You think about this picture. So 100 mosquito bites at once in your bladder. Everywhere you've got a red spot, potentially you have urine reaching deeper into that tissue, causing mast cells to release histamine. Histamine is what causes the swelling, the itching, and the pain of mosquito bites. And so what we do see is a lot of histamine activity in the bladder wall. That was something that Dr. Theoharides originally discovered in his early research with IC. And so using an antihistamine makes total sense. The nice thing about the hydroxyzine is that it also has some beneficial side effects, specifically as an anti-anxiety agent. It can help just kind of calm your anxiety, make it a little bit easier for you to sleep, which is not a bad thing. I took hydroxyzine for about 8 or 9 years. And the only reason I stopped it back then was because I finally got what we call hydroxyzine dreams. Hydroxyzine really messes with your dreaming. And I ended up with nightmares that became night terrors. And so that when you're on hydroxyzine, your dreams get super intensified. So if you're having a happy dream, it becomes a joyful dream. If you're having a good sex dream, it becomes the best sex of your life dream. And if you're having a nightmare, it becomes a night terror. And that's what happened to me. I started having night terrors. And as soon as I stopped the hydroxyzine, the night terrors went away. So Jessica, pay attention to your side effects. It can also cause some dry mouth too, to see how you do with it. It took 8 years for that to happen to me. It really helped me through a really rough spot of my IC those first 5 years or so. Jessica said that she had no flares from the Moderna vaccine. Deborah said she got the J&J vaccine and she has Hunter's lesion. She had no flares from the vaccine. Marie, thank you so much for your 50 stars. I really appreciate it. I'm a little scattered today. Not feeling my best today. Afton said, my mom has IC. I'm worried I may have it too. Nervous to get a hysterectomy if that's not the reason for the blood pressure and the bladder symptoms. Well, hon, I mean, why, there has to be a legitimate reason to have a hysterectomy. If they're just saying, hey, let's do a hysterectomy and let's see if your pain goes away, that's not good enough. That's not good enough. And we've actually had some really good litigation here in the United States. There was a woman who won $1 million from the US Navy because her gynecologist removed her perfectly healthy bladder, even after the urologist said it was her bladder. Okay, hold on. Did I get that right? The gynecologist removed a perfectly healthy uterus because the gynecologist was convinced that the uterus was the cause of her pain, even though before the hysterectomy in the OR, the urologist confirmed it was her bladder. And this patient won $1 million. And that's not the only time that that's happened. That's why we do something called the PUF questionnaire. The PUF questionnaire is a good way that a gynecologist can help differentiate between bladder wall pain versus uterine pain and reproductive pain. Jessica says, yeah, I've had more enhanced dreams. That's what it's doing. Right. Isn't it interesting? It's very, very interesting. So Afton says they're saying it's uterine prolapse. Well, it's a tricky situation, Afton. There's a wonderful website called Hyster Sisters. HYSTERSISTERS. Hystersisters.com. Afton, I would go over there and join them. They're a wonderful support network for patients who are exploring hysterectomy or having hysterectomy. That's who I used when I had my hysterectomy. Oh my God. I had my hysterectomy 4 years ago, almost to the day. Holy crap. That's an anniversary you don't want to, now I had my hysterectomy because I had something called complex endometrial hyperplasia with atypia and a vague architectural complex. What that means is that I had the earliest signs of uterine cancer. And so that's why we did it, because we thought my uterus was filled with tumors. It turned out it wasn't. It was just early. I have a video, Afton, on our website of my cancer story there and kind of what I went through and kind of some of the mistakes that I made along the way. You might want to watch that. It's over on YouTube. Carol says, what do you think about embedded infections? So many are saying IC. I'm saying they're wrong. I'm saying they're absolutely wrong. We cannot make blanket statements that every IC patient has embedded infections. They are wrong. I don't know a single major IC researcher who agrees with that. We have subtyping. So the first thing we have to ponder, again, is what about the patient who's got IC symptoms because they have a fibroid tumor pushing on their bladder? Okay, that's not an embedded infection. What about the patient who has IC because they've got endometriosis growing on the outside of their bladder? That's not embedded infection. What about the patient who has a Tarlov cyst coming off of their spine? That's not infection. What about the millions of patients who get IC symptoms because they have tailbone injuries or muscle problems, or their symptoms began after having a baby? That is not chronic infection. Yes, there's a vocal group of people who are telling everybody this is chronic infection. They're wrong. And if you look at the data from next generation DNA urine testing, what do we know? For one thing, it's not chronic bacterial infection. Some of you have chronic candida infections. Why? Because you're taking too many damn antibiotics. If there's one group of patients who is completely overexposed to antibiotics, it's us, the lower urinary tract patient. How many of you have antibiotics that you take home whenever you have a flare? You drink a cup of coffee, you have a flare, you go, I better take my antibiotic, even though you damn well know it's a cup of coffee, right? So our own MAP Research Network, over $100 million dedicated to IC research. They have never found the same chronic infection in every patient. In fact, they're the ones who are supporting subtyping. Their data continues to support variant subtyping in this very heterogeneous population of patients. You're like snowflakes. Everybody's different. Not everybody's the same. So some of you could have chronic bacterial infections. Yes, not all of you. A small percentage of you, yes, I will give you that. Some of you, more of you, could have chronic candida infections. We have the research that proves that. I myself had a 2-year candida infection from doing long-term antibiotics on the old Fugasata protocol. I had a candida glabrata infection that was completely drug resistant. Took 2 freaking years to kill it, all because I took too many antibiotics, because back then we thought bacteria. This was 20 years ago. Move on. Move on. And of course, now we have all the new viral data. Polyoma. An antibiotic is not going to stop a polyoma infection. What an antibiotic is going to do is destroy your biome and make you even more prone to candida infections. It's going to disrupt those normal checks and balances that keep bacteria functioning in a good way rather than in a pathogenic way, right? So I am not on the embedded infection bandwagon. And I don't know any top researcher who is. And in fact, if you look at the AUA guidelines for IC, they specifically say do not use long-term antibiotics to treat this. One of the other issues that I have is that some people in the embedded infection theory don't believe in any testing. They just say take antibiotics for a long period of time. It's like, no, for God's sake, you got to know what the hell you're treating. I mean, at least have some sort of test to see if they can find something. And that's where the next generation DNA urine test is so important, because rather than trying to culture something out, grow something out, what they do is they look for pieces of DNA and they identify what's living in your bacteria or potentially dead. I mean, your urine, or even dead in your urine. They're just pulling pieces of DNA and stuff out of your urine, and they're identifying it. What's in there? Good bacteria, bad bacteria, fungus, virus. And the challenge here, I mean, listen, there isn't a part of this that is not controversial. There are going to be people who fight every element of this. You know, opinions are strong right now. Some people love next generation DNA urine testing, like Dr. Curtis Nickel, who gave a lecture last year and said that it was the future of all urine testing. And some people hate it, and they believe that the companies are grabbing money. I like data. To me, the value in a next generation test is if you think you have infection, it will tell you. If you are absolutely 100% convinced that you have infection, have the next generation test and let's see what grows out. And if nothing grows out, then you can walk away from that theory that you have infection, in my opinion. Now, I'm going to get hate mail from people for saying that. But that is my opinion. It is what it is. It's data. It's useful, meaningful data, potentially. But it's also very hard to interpret. Because if you come out with small amounts of bacteria, well, it may be that you're supposed to have those small amounts of bacteria. We don't know enough about a healthy urinary biome to say exactly what it should be. Our biome has been destroyed for years by antibiotics. And so we don't know what the normal is. Nobody knows what the normal is in the urinary biome right now. We don't. It's been too disrupted. The only place where you're going to find normal biomes are a couple of tribes down, in South America or in Africa who are not exposed to modern foods and medicines. Don't get me started. And don't send me hate mail. I don't need your hate mail, guys. This is my opinion. You're not going to change it. Sherry says, I've been bedridden for almost over a decade with pain. I have also thought about InterStim. I know someone who had a terrible time with infection, so I decided against it. Afton says, my doctor wants to do a laparotomy to exploratory surgery to check for other issues like endo. Afton, that's exactly what I did in September of 1993. I insisted on it. They told me I had IC. I said, I don't believe you. My pain is so severe. I'm sure I'm dying of cancer. For God's sake, open me up and take a look. And my gynecologist was like, sure. You want me to do a laparotomy? I'll do a laparotomy. Let's look in your belly, see if we can find it. And I woke up in the recovery room. Jill, there's nothing in there. You're fine. You're not dying of cancer. You know, that's what pain does. You know, pain triggers fight or flight. It's very normal to catastrophize. It's very normal to think the worst is happening, especially every time you have a flare over and over again. We call it the runaway train. You know, pain will always trigger an emotional response. And it's important to kind of learn to step off that train. So if you flare every time you ovulate, you don't have to get upset every time. It's you're just ovulating. It's a short-term flare. You know that. But if you were a smoker and you have a history of smoking, or if you have blood in your urine, or if you just can't stop thinking about it, like for me, for a year, I just thought I was dying of cancer. You know, that's bladder pain. Bladder pain is characterized by being relentless and difficult to ignore. It's exhausting. It's exhausting. I thought I was dying. And so I begged him. I said, I don't believe you. I don't believe that I have IC. I think I have cancer. I think you've missed something. Open me up. And he's like, okay, nothing. But I needed that at that time. I needed to know that at that time. So, you know, and they ruled out endometriosis, they ruled out fibroids, and that was just very helpful for me. I wouldn't do it now. I mean, because you can just do a urine cytology test, and that will also tell if there's a risk factor. But I did smoke a little tiny bit in college, so I thought, clove cigarettes. Who didn't do clove cigarettes in college back in the day? To be cool, back in the days when I thought you needed to be cool and do what other people were doing. Annie says, can the vaccine increase bladder pain? I've had this severe flare since the vaccine. For a small percentage of people, it has been known to trigger a short-term flare where you have more pain for maybe a week or so. Carol says, thank you so much for answering my question. I've had IC for 13 years. I'm getting frequent UTIs. I was getting confused by those saying it's all embedded infection. So Carol, we would want to really look at estrogen atrophy. The biggest risk factor for long-term chronic UTIs is going to be aging and the loss of estrogen. Jessica says, is it easy to file for disability? Yes, it is. She said, I'm currently unemployed because I can't work. Or have you heard anything on anybody getting disability? So with disability insurance, you guys, you have to know that there are four different types of disability insurance. The first one is private insurance. That's from your employer. So check your personnel policies and see if you're covered by disability insurance through your employer. The second thing we want to look at is Social Security disability. Social Security disability is long-term disability insurance that you have paid into. It is an insurance plan. It is deducted from your paycheck. You are eligible for Social Security benefits if you have worked about 10 years or earned 40 quarters of credit, or if you're in your 20s, there's a special test for that. You don't have to work as many, but you might still be qualified. The intention of Social Security disability is that you will never be able to work again. It is long-term disability insurance. In contrast to the third type, which is state disability, also known as SDI. Many states have state disability insurance. This is short-term transition insurance. This is the disability insurance you use when you have a baby, or if you're in a car accident, or if you break your leg. So SDI is possible. And then we also have SSI, supplemental security income. That is for the people who are the most profoundly disabled, who have never been able to work. Obviously, SSI benefits are going to be very, very low. So can IC patients get disability insurance? All the time. All the time. You come on over to our website, icnetwork.org. I have a whole disability resource center in there. Generally, you have to ask yourself, let's see, how do I want to say this? I went out on SDI for a year. I did. My pain was so severe, I was driving to work sobbing every time I hit a speed bump, and I just couldn't work. And so I went out on disability benefits, SDI, and that's when I had my laparotomy to rule out cancer and all that sort of stuff. And then at the end, the nice thing about SDI is that you can work. You can start working again, and then you report your income to them and they reduce your check. It's not a lot of money, but it's enough to kind of, it's better than nothing, right? Um, and then at the end of that year, your benefits time out. You only get a year. And that's when, and maybe even 6 months before that, that's when you start the process to apply for Social Security disability. If you meet the benefit, if you meet the quarters and you paid into it and you're qualified, it could take 6 months to a year to get your Social Security disability. So SDI also acts as a nice transition until you can get your federal benefits. That said, I did not go for the federal benefits. Even though I was still struggling, I made the decision that I wanted to work. I was not going to give up. I was going to work. And so I started working part-time from home, even though I had IC and even though I was still having a lot of pain. I was writing, I built our website, working for some, I was designing PR materials and brochures and all sorts of stuff like that, working on my doctorate stuff like that, things like that. So, one other thing about Social Security disability is that, and Social Security in particular, is you have to have worked in the previous 10 years. For God's sake, don't stop and wait 10 years to apply because you'll time out and you won't be you won't be eligible. That did happen to an IC patient in San Diego I worked for. She was just she was out, but she was making it, but barely, right? And she always thought, I'll get disability. And then finally she just stopped working. She went off of all of her savings, used all that up, and she timed out by like a couple of months and she wasn't eligible for her benefits anymore because she hadn't worked. So if you have the opportunity to even work part-time to earn those quarters, that's important. Being paid under the table does not help you in the long run when it comes to disability benefits. You need to earn your quarters. So even if you're making $500 a month or $500 a quarter, it's important that you report that because that will be the foundation for your future Social Security applications. Also, let me just say one other thing, Jessica, about Social Security. Let's see. I have worked with thousands of patients over the years, but there's one patient in particular who is an absolute hero to me, because she took her Social Security denials all the way to federal court and won. And she won. So what happened to her, she had two really horrible things happen. The first thing that happened is she was working in a car factory. And it was an Asian car factory. And they did not believe that she needed restroom access. And the treatment she got from her supervisors was nothing short of astonishing. She had doctor letters. They didn't want her off the factory line. Normally, patients are told to wear diapers, yada, yada, yada. Her abuse got so bad that in a meeting with her supervisor, she was asked to demonstrate how she self-catheterized. True story. True story. And that became the scene of a whole ADA thing. Can you imagine? Can you imagine being a woman, walking into a room of men, laughing at you, telling you must demonstrate how you self-catheterize? That's how bad the environment was 25 years ago. So that was one of her things, and she won that eventually, which was good. but the second thing that happened is she applied for Social Security benefits, and her case was pretty severe, obviously. If she was self-catheterizing at work, it's obviously very severe. So when she applied for Social Security, she was denied. Now understand, 80% of applications are denied pro forma your first application. Do not walk away. It's a test. It's basically a test to see if you're willing, if you're going to go for it. They count on the fact that people are going to walk out with the first denial. Do not do that. When you get your first denial, you will get an opportunity to do a reconsideration. And that is where you can submit more information, and you will have another disability specialist look at your case and look at the data that you've given them. You definitely need at least one doctor who's going to say that they believe that you're fully disabled. In her case, the Social Security employee ruled against her because he said that frequency wasn't a good enough reason to get disability benefits, even though she had to pee every 15 minutes and had to leave the production floor. So she got denied again. She appealed it again. And in front of the administrative law judge said, well, your doctor never witnessed your frequency. Therefore, there's no proof that you have frequency. Therefore, we believe you're making it up. Therefore, you can still work. And so an administrative law judge said a doctor must have witnessed her frequency to make her case count. And her attorney was like, but the doctor is not there in the middle of the night when she's peeing all night. So they took it all the way up to a federal judge. And I think it took 2 or 3 years to go through this entire process. And the judge ruled in her favor. The judge was like, you're absolutely right. There's no way that a doctor can witness frequency. The challenge here is that our symptoms are subjective: frequency, urgency. And what would have turned her case around is if she had given her doctor a simple voiding diary at every appointment. And that's one of the things that we tell patients to do now, is that if you've got more severe symptoms, it's important that you do like a 3-day voiding diary. And every time you go to the doctor, have them put it in your medical records, so that 2 years from now, 3 years from now, 5 years from now, 10 years from now, there's written proof you have frequency. And if she had done that, she would never have had to go up to a federal judge to get her approval. Also understand too that they evaluate the totality of you. So you're not just going to report that you've got bladder symptoms. If you also have bowel symptoms from IBS, you've got to put that in there. If you've got anxiety, you've got to put that in there. You've got to build a case that shows that you are so disabled, you are not going to be able to work. So we do have a Social Security ruling for IC. IC is not listed as an automatic approval, but there is a nice ruling that helps Social Security employees evaluate the typical IC patient. But really what I want for you is, if we can get down to the fundamental problem of what's causing your symptoms, let's try to get you better so you can do what you love, so that you can care for your family, so that you can go to work, so that you can follow your dreams. Right? Now, I mean, remember, now we know why Elmeron didn't work for so many patients, because a lot of you don't have bladder problems. You've got muscle problems. And if you invest your money in the right way, doing muscle therapy and trying to repair and restore the totality of your pelvis, we could get you back to the point where you might be able to go to work again. I hope that makes sense. And some of you out there just don't want to. I got a letter from somebody, I won't say who knows that they have tight muscles. They know that that's the problem, but they just won't do the therapy. It's like, why? What do you have to lose? Pain, come on. Your muscles can get hurt down there. It's okay to let somebody touch muscles down there. And yeah, it sucks that it's got to be done vaginally or through or rectally. But these are potentially fixable. And when Chris Payne released his 5 subtypes for IC, he ranted on the fact that so many patients are told that this is incurable when it's not. For some of you, it is completely curable. If you have if you have a tailbone injury and your tailbone is healed out of position and that's tweaking your pelvic floor, that might be fixable. If you have a fibroid tumor pushing on your bladder, that is fixable. We're long past the days of saying that IC is an incurable bladder disease. We haven't done that for a decade. It is a pelvic pain syndrome. Why? Because structures outside of the bladder are often involved. Thank God we know this now, right? Thank God we know this now. Cassie says, I'm definitely in the category where I drink or eat most things that are on the no IC diet. However, since I got the Paragard IUD and I get horrible pelvic pain and flares, in the past I was told I had Hunter's ulcers. So IUDs and birth control are really well known now in some patients to trigger IC symptoms. We had a very good case study released last year of an 18-year-old girl who suddenly developed symptoms of IC, frequency, urgency, pressure, pain over a period of a year. She had multiple diagnoses. She was told she had IC, candida, you name it, she was told. Finally, a doctor said, "Hey, did you start birth control?" And she goes, "Yeah." "Well, let's stop it." And when they stopped her birth control, all of her bladder symptoms went away. It took about 2 months, but they did. When you artificially raise and lower hormones, you're going to be changing your urinary tract to a certain degree. And there certainly are patients who have problems with some forms of birth control affecting their bladder and their bladder symptoms. So I'm assuming, Cassie, that that's an IUD. Anne says, do flares always come with pain? Nope. Sometimes people just have frequency urgency. Carol says, I use estradiol 2 to 3 times a week. Is that enough in your opinion? Depends upon what your skin looks like. If your skin is super dry, even with that, your doctor might want you to do a little bit more. It's fairly normal with topical estrogen. Guys, you can look at the research yourself. Just Google safety topical estrogen. The safety profile is remarkably good when you're using estrogen in a topical formula. And generally what will happen is if you've got really severe estrogen atrophy, they might have you do it every day for like 2 weeks, 3 weeks, and then go back down to 3 times a week or 2 times a week. But I can't give you medical advice. You got to talk to your doctor about what's appropriate for you. They have to look at your skin. Marie says, I'm taking letrozole for estrogen positive breast cancer and I'm in my 70s. Could this be causing my pain? It might be. There are certain forms of chemotherapy that release remarkably toxic chemicals that damage the bladder wall, but there's another medicine they can give you that renders that chemical inactive. Let's look it up here. I'm just curious. I don't remember. I don't remember the brand name of the. Let's see here. All right, side effects, less common: bone fracture, breast pain, chest pain, chills, mental depression, swelling, rare. So they do report an increased need to urinate with lestrol. Passing urine more often, painful and difficult urination, Yeah. So I'd say, yeah, that's certainly possible. You would be in that category of chemocystitis. Jessica says, my bladder's affecting me so badly I can barely move. So, Jessica, I'd really want to know what's going on with your pelvic floor muscles because your bladder, in essence, shouldn't be like a UTI normally doesn't hurt when you're walking as compared to a pelvic floor injury would really hurt when you're moving your muscles and walking. I mean, obviously, nothing's going to be happy down there. But the fact that you can barely move, whenever somebody has pain that is associated with movement, we're always going to be looking at the pelvic floor muscles also. Will an Epsom salt bath help my pelvic floor pain? Yes, it certainly could. Absolutely. Kalina says, last week you mentioned urethral diverticulums. Can you explain this more? I'm not sure if I have a urethral prolapse or a urethral diverticulum. I want to discuss this with my primary care provider. My appointment is until July. So a diverticulum is basically like a little tiny tube. So imagine that you've been straining and well, sometimes it can be a birth defect too. Sometimes you can have a birth defect. So um, gosh, what's the right word for this? Think of a hernia. Think of it like a little tiny hernia off of your urethra, where tissue so your urethra is normally like the size of your little finger, right? But whatever structure that would normally keep this in place has been weakened or damaged, and so when you push or strain, you start getting a pouch off of it, and it can get bigger and bigger. So that's more of an example of a prolapse where you can get a big one, but with a diverticulum, it's like a little tiny tunnel. And so in the case of the patient I was talking about, what happened is she ended up with a pouch that extended the length of her urethra from low to high through a diverticulum. So it was like an H shape. So urethra, pouch, little tiny tube connecting the two. And it was urine collecting in the little tiny tube that was the issue there. Linda says, is there any new treatment on the horizon for Hunter's ulcers? Well, yeah, because we're now really looking at the viral connection. The more data that's coming in that's supporting that Hunter's lesions could be coming from viruses, I'm sure they're going to start testing more for viruses and maybe using antivirals. And of course, we still have Lyris out there, which has been shelled by Algonaut. Somebody said it's okay to be fired. It will only help your case. Yeah, guys, the only time I've ever been fired from my job was because of my IC. I got fired and it hurt. Damn. I mean, it was here. I was in experimental therapy. I was crying to get to work, but I was still doing my job and I had to go out on disability. And they fired only people on disability and they were jerks. But eventually I filed a disability case against them and eventually they settled, but that's a whole nother story. Sally said, been in remission for a year, back full force suddenly without warning or reason. So Sally, what that means is something got hurt again. So did your pelvic floor muscles get injured in a flare? Or did you injure your bladder wall with some sort of chemical exposure? Or is it accumulated stress? Or could it actually be COVID? And Jessica says here, you have sciatica, so you absolutely have pelvic floor dysfunction. So you've got to be working on that. That's important. The impact that tight pelvic floor muscles have on the bladder is absolutely undeniable. Undeniable. All right, you guys. Well, listen, I'm not going to do the Zoom meeting today. I am not feeling well. I have a lot of back pain, and I need to go lay down and take some medicine for my compressed disc. Sylviane says, is it possible to never go in remission? And people go into remission all the time, but remission isn't really the right word. This is about healing. You know, a lot of people say, when will the cure be found? And it's my answer is always, well, you don't cure an injury, you heal an injury. So, Sylviane, it begins with your underlying anatomy. We have to understand what the fundamental problem here is. So, it could be Hunter's lesions, it could be something related to your bladder, it could be estrogen atrophy. If it's estrogen atrophy, we're not going to cure estrogen atrophy because that's aging, but we're going to give that tissue a little bit of estrogen so that it can start producing mucus. If you've got a chronic fungal infection, we want to treat that. That's curable. If you've got a pelvic floor injury, that is treatable and potentially curable. If you've got pudendal neuralgia, that again, that's challenging. We got to work with muscles and calm nerves down. And then last but not least, if you've got chronic overlapping pain conditions, we've got to calm your whole central nervous system down. So yes, people get better all the time. I am living proof. I had a doctor say to me, you will live in severe pain for the rest of your life. I have not had severe bladder pain in years. I've had severe muscle pain. Now that I know the difference, I understand now that what I thought was my bladder actually was my pelvic floor along with my nervous system. So anyway, you guys, thank you so much for coming today. I got to cut it short. I got to cut it short. Wish me luck. Wish me luck. I got to get this nerve calmed down. Okay. So y'all be well. If you need to get a hold of me, tomorrow's my day off. You can get a hold of me at the IC Network office starting on Tuesday. And all the freebies from last week have been mailed. We're going to have our brand new book, should be done soon. It's called IC 101. It's not just a bladder disease. Doing the very last final edit on that. We will have Sister ProTech coming in. And if you find these meetings helpful, don't forget, you can come on over to our website and get our magazine, the IC Optimist. This was our latest magazine. I always want to do a big shout out to the gentlemen who have IC and pain because they are often ignored and don't get the treatment that they need. Do have two very good case studies in here of men who are essentially cured with pelvic floor work, even after they were just diagnosed with prostate and bladder stuff. All right, so come on over and check out our magazine too. I'm sorry for being a little bit scattered, but I'm human too. And there are moments when it just hurts. And today is one of those days. So I'm going to, Carol says, your tissues and skin look great. Okay, well, if your skin looks good and you're not showing an estrogen atrophy, then we can move on to some of those other things. I'd be happy to talk to you offline. All right. Okay, you guys, I'm going to cut it short. I'll see you later. I got to go put my feet up.